This is Dr. Jacob Baranowski, and this is the lecture for the Natural History of Cavernous Malformations chapter. The objectives for this lecture are as followed. We will review the natural history of cavernous malformations. We will discuss the various types of radiographic appearance of cavernous malformations and the implications of these patterns on the natural history. And we will discuss a treatment recommendation algorithm based on the natural history studies and large surgical series. As a point of introduction, cavernous malformations are low-flow vascular lesions that occur throughout the central nervous system. Lesions in the cerebral convexities tend to present with seizures, while lesions of the brainstem tend to present following a hemorrhage with associated neurological deficits. Cavernous malformations can be broken down into the familial or sporadic subtypes, and overall these are relatively common lesions, presenting in 1 out of every 200 to 250 persons. The natural history of cavernous malformations depends on multiple factors. These include the anatomic location, the clinical presentation, and imaging characteristics. The hemorrhage risk of a cavernous malformation also is based on its location, whether or not it's in the brainstem or the cerebral convexity, whether or not the lesion initially presented as symptomatic or asymptomatic, and based on specific radiologic subtypes. To help differentiate which cavernous malformations are more likely to re-rupture, a MRI classification system has been developed. Type 1 lesions are those with acute or subacute hemorrhage, and these are broken down into type 1A and type 1B. Type 1A lesions have a hemorrhage that extends beyond the lesion capsule and is associated with significant surrounding edema. Type 1B lesions are those that have acute or subacute intralesional hemorrhage but do not extend beyond the lesion's capsule. Type 2 lesions have a mixed imaging quality, in which is indicative of resolving hemorrhages of various ages, and this is consistent with prior episodes of bleeding. Type 3 lesions are those with a chronic hemorrhage pattern with a resolving hemorrhage, and type 4 are those lesions that have no evidence of prior hemorrhage at all. We will now go through specific examples of each of these lesion subtypes. Here we see an example of type 1A, which is an acute or subacute hemorrhage that extends beyond the lesion's capsule. On this image you can see the cavernous malformation, but with an acute hemorrhage that extends beyond its capsule wall. These lesions are nearly always symptomatic, and they have a high risk of recurrent hemorrhage. Here we see an example of a type 1B lesion, where there is an acute hemorrhage of a cavernous malformation. However, this hemorrhage remains within the capsule wall. These lesions can be symptomatic if they occur in an eloquent region of the brain, and the rehemorrhage risk for these lesions depends on a couple of factors. One, if the lesion was initially symptomatic, they tend to have a higher rehemorrhage risk than if the lesion was identified incidentally. And further, brainstem lesions tend to have a higher rate of rehemorrhage compared to convexity lesions. Here we see an example of a type 2 lesion, which is a mixed pattern of previous hemorrhage and resolving hemorrhages. This tends to have a loculated area within the cavernous malformation seen on the MRI and is surrounded by a gliotic hemosiderin-stained brain. For type 2 lesions, the rehemorrhage risk is again based on whether the lesion presented initially as symptomatic or asymptomatic and the location of the lesion, such that symptomatic lesions have a higher rate of rehemorrhage and brainstem lesions have a higher rate of rehemorrhage compared to convexity lesions. This is an example of a type 3 lesion, which is termed a resolved hemorrhage. You can see a focus of resolved hemorrhage within the hemosiderin staining on this MRI image, and these tend to be better visualized on T2 weighted images and can possibly be missed on T1 images if the resolved hemorrhage is remote enough. These lesions tend to be asymptomatic and overall have a low risk of symptomatic rehemorrhage. Finally, here is an example of a type 4 lesion, which are those lesions that have no evidence of prior hemorrhage. These can be easy to miss on T1 or even T2 images, as there's no evidence of hemosiderin staining, but are easily picked up on gradient-rated echo and susceptibility-weighted imaging sequences. These lesions are almost always asymptomatic and have a low risk of hemorrhage. When deciding when to operate on a cavernous malformation, the risks of the natural history must be weighed against the risks of surgical resection. Here are some important factors to consider. The first is the clinical presentation of the patient. Recall that the risk of recurrent hemorrhage is higher in symptomatic patients than those who presented asymptomatically. We also discussed the multiple radiographic subtypes of cavernous malformations based on their MRI appearance and the associated risks of re-hemorrhage based on the initial MRI characteristics. Whether the patient is presenting with the sporadic or familial form of cavernous malformations is also important to consider, as is the lesion location. And recall that the risk of recurrent hemorrhage varies by location, with a higher risk of hemorrhage for those lesions located in the brainstem. But however, it is also important to consider that the risk of surgical resection varies by these locations, and the risk of operating in the brainstem is higher than operating in the cerebral convexity. While the actual decision of which lesions to operate on is highly nuanced, we have devised a clinical decision-making algorithm to aid in the decision of which lesions are best treated conservatively versus those that are best treated with operative intervention. This is broken down based on the lesion location, the clinical presentation, whether or not the patient has single or multiple lesions, and then we give our recommendation based on the amalgamation of these characteristics. Working through this table here, we see that if a patient has an incidentally discovered and asymptomatic cavernous malformation of any location, the best course of action at this point is simply observation. If the patient, however, has multiple incidentally discovered lesions, we would recommend observation and genetic testing to see if the patient has a familial form of the cavernous malformations. If a patient presents with their first-time seizure and a lesion located in any location, we would recommend an initial trial of anti-epileptic medication prior to proceeding with surgical resection. Likewise, if a patient has multiple cavernous malformations and presents with a first-time seizure, we would recommend beginning anti-epileptic medication therapy and also proceeding with genetic testing to identify if the patient possibly has a familial form of the disease. If these seizures can be well controlled on anti-epileptic medication, it is possible that surgery is not necessary. However, if a patient presents with a supratentorial cavernous malformation and medically refractory epilepsy, resection may be indicated. If a patient has a single lesion that can be identified as the source of the cortical irritation and associated seizures, surgical resection may be recommended. For patients who present with their first-time hemorrhage with an acute neurologic deficit, and the lesion is located within a non-eloquent cortex or the cerebellum, we recommend resection as the first-line treatment. This decision becomes more nuanced if the lesion is located in either deep or eloquent cortex or in the brainstem. For patients who present with their first-time hemorrhage with a focal neurologic deficit and a lesion located either in their deep cortex or their eloquent cortex, we recommend either observation or resection based on clinical presentation and anatomic characteristics. We would determine a favorable presentation as one where the patient presents with fixed neurologic deficits, such that there is no anticipated increased risk of neurologic morbidity associated with the surgical approach, and we consider favorable surgical anatomy to be a lesion that abuts a peel or ependymal surface, or where the hematomatous cavity has provided a safe surgical corridor. We have a similar decision-making algorithm for lesions that appear in the brainstem. If a patient presents with a first-time hemorrhage and focal neurologic deficit from a solitary brainstem lesion, we again recommend either observation or resection based on the clinical presentation and anatomical characteristics. We know that lesions in the brainstem have a higher rate of rehemorrhage if they present symptomatically, so we do recommend for patients that have had a recurrent hemorrhage and the lesion located in the deep eloquent cortex or in the brainstem, that resection may be indicated if it is deemed appropriately safe, again based on the anatomical and clinical presentation. I wanted to spend some additional time discussing brainstem cavernous malformations. Brainstem and deep cerebral lesions have a higher risk of surgical morbidity, and therefore the decision to operate on these lesions carries more risk. In general, we recommend reserving resection for patients with one of the more following indications. 1. A history of multiple hemorrhages from the cavernous malformation. 2. Severe or progressive neurological symptoms. 3. Acute or subacute hemorrhage with significant mass effect pressing on these eloquent structures. We also ask that one of the following favorable anatomic features are also present before deciding on whether to operate on these deep lesions. If the lesion abuts a peel or ependymal surface, or if the lesion has an acute hemorrhage that extends outside the lesion capsule with surrounding edema, we believe that these lesions are more amenable to surgical resection. When deciding to operate on a deep or brainstem cavernous malformation, it is important to recall that incomplete surgical resection is associated with a high risk of recurrent hemorrhage. This highlights the importance of a complete surgical resection if surgery is undertaken, as you do not want to subject the patient to a risk of surgery if you are unable to fully resect the lesion and therefore remove the risk of recurrent hemorrhage. While these lesions are difficult to treat, good outcomes are possible in a well-selected patient population and at an institution where there is significant experience with treating these difficult lesions. In conclusion, the natural history of cavernous malformations depends on anatomic location, clinical presentation, and imaging characteristics. The decision to resect a lesion should take into account the risks of the natural history versus the risks of the surgical resection. For these lesions, good outcomes are possible in a well-selected patient population.